It's an honor to be here. Thank you for the invitation, and I appreciate everybody hanging around on a Friday afternoon to listen to my talk on PJK. Here are my disclosures. So PJK is something that has been studied for the last probably 12, 15 years. It's been of great interest to many spinal deformity surgeons because it's something that really could compromise our outcomes. The definition of this was described first in 2005, demonstrating that a PJK angle of 10 degrees and 10 degrees greater than pre-op comparison is the definition for this. And this is what we use today to communicate about this entity. So, for example, in the two figures that you see here, if the angle on the right was only 25 degrees or 24 degrees, it would not meet the criteria to be PJK, even though it's more than 10 degrees. So those are the two criteria that you need to have the diagnosis. Now, PJK occurs everywhere in the spine: lumbar spine, thoracolumbar spine, cervical spine, proximal thoracic spine. And we really try to work with the SRS as well as the spine journal in order to have a good definition for this. And in this series, we basically performed a systematic review demonstrating that the rate of adjacent segment pathology as far as PJK was concerned could be as high as 40%. Now, the reason why we're concerned about it is that it's clear that patients who have PJK, they have more complications, they could develop neurologic complications, and they also have compromised SRS outcome scores. The other issue is that PJK, it's becoming more and more clear that PJK can cause cervical deformity. And cervical deformity is a big problem because if you develop cervical deformity, you have a compromise in your outcomes and a higher level of disability. So this was a paper where we looked at patients who had higher cervical sagittal alignment. And we found is that those patients who had worse alignment were more likely to have higher NDI scores. Now, why does it happen? So many things have been studied in order to find the etiology for this, ranging from the posterior tension band, the rigidity of the construct, poor host bone, instrumentation type, as well as excessive corrections. Here, this is a study where we actually found that patients who were older than 50, patients who had osteoporosis or osteopenia were at higher risk, and those patients who had large SVA correction also at high risk. Now, I brought this slide up because I presented this at the SRS meeting in Lyon in 2013, basically demonstrating that as we started to pay more and more attention to the sagittal parameters and the importance of it, what we see is also right behind that trend. So the blue is the number of papers on PubMed that talk about the sagittal balance. Then the green is the number of publications that talk about PJK. So I think a couple of the reasons why PJK is occurring more frequently is because we're paying attention to the sagittal plane, achieving greater corrections in the sagittal plane, and also starting from around 2002 and 2003, the use of all pedicle screw based constructs. So many years ago, maybe 15 years ago, people used to always say, can you ever have too much lordosis? And I remember surgeons in the United States used to say, you could never have too much lordosis. You have to try to get as much as you can. But I'm not really sure if that's true. What we found is that actually those patients who had excessive lumbar lordosis, as well as those who had large SVA corrections, they had an 80% chance of developing PJK. It's not very good. So the question is a SVA of 0 and what the sagittal balance papers talk about and stress, is that really true and is that really necessary? And I would argue that that's not true. If we look at patients who are asymptomatic and we look at how they age, there is no one SVA that's perfect for somebody through the rest of their lives. So if you see somebody in their 40s, their SVA as well as their lumbar lordosis is going to be less than lumbar lordosis will be larger and their SVA will be less than somebody who's in their 70s. And we did a study also looking at this, showing that if you're going from your 40s to your 70s, for example, you have a decrease in your lumbar lordosis from 60 to around 47, and your SVA increases by about 3 to 4 centimeters. Now, these are totally asymptomatic people who have never missed a day of work because of back pain symptoms or never had spine surgery. So this is the normal progression of sagittal alignment with aging. So here's an example of a case that was referred to me, and severe pseudarthrosis, junctional kyphosis, screw pullout, patient who was 70 years old with severe osteopenia, and I performed a revision operation and got an excellent alignment. But although it looks like excellent alignment, the question is this 70-year-old person really able to sustain and handle a SVA and a SVA correction of 0? And I would say that here's the follow-up just 6 weeks later, and then about 3 months later, 6 additional weeks after that. And the patient was then walking, tripped, and then developed this with acute paraplegia and needed an emergent surgery in order to reduce her spine. So these are catastrophic injuries. This patient actually had a sustained ASIA injury and was never walking again. So if we look at the traditional literature everybody quotes about SVA, what we see here is that Glassman's landmark paper talking about as you increase your sagittal balance, your level of disability increases. But what I want to submit to you is that actually if you look at this and you look at the numbers critically, what you see is that between a SVA of 0 and a SVA of 5, the ODI is really up and down. So the correlation is not very good. It starts to become more correlated when the SVA gets greater than 5.5 centimeters. So I believe that actually having a patient who is corrected between 0 to 4 centimeters, for example, is actually a sweet spot where you could potentially minimize the risks for developing issues like I showed in the case before. So this is another example of a patient who is not in her 70s. She's in her 40s, underwent a major realignment operation, 3 years post-op, maintaining her alignment, not one evidence of PJK. So I believe this is real. The other issue is the prevalence of neurologic disorders in these patients. And this is another paper by Steve Glassman demonstrating that there's also a 76% prevalence of neurologic disorders, such as Parkinsonism, patients who have neuropathy, myelopathy, or very poor proprioception in these patients. So I believe that's also a contributing factor. Now, the reason why PJK is also a big problem is that if it happens once, it's more likely to happen again. And there's very little literature out there right now talking about recurrent PJK, but when we looked at the rate of recurrent PJK through the ISSG, what we found is that the rate of recurrence is 45%. So that's very high. The problem is, if it happens again and you need a revision surgery, the chances that you're going to need another revision surgery for it happening again is even higher, at 43%. At least when PJK happens the first time, your chances of needing a revision surgery are relatively small, 5% or so. The other issue is the cost. So in a cost-conscious health era, what we found is that your first operation may be close to $70,000, but if you need a revision surgery, whether it be a thoracolumbar or upper thoracic PJK that needs a revision, the cost of the revision surgery is almost as much as the indexed operation. So this is obviously something that we really want to try to avoid. Now the literature has looked at many ways to try to avoid this, and I'll go through some of them. Biomechanically, they've looked at things such as vertebroplasty, adjacent segment. And biomechanically, it makes a lot of sense. Cal Kabesh studied this biomechanical data showing that the forces that you could sustain with cement augmentation are significantly higher. You can see on the left, 2,500 newtons versus 4,000 newtons of force, compressive force with cement. So it makes a lot of sense biomechanically, but the issue is that we have not seen that to be true in the clinical setting. There have been multiple papers demonstrating that even with cement augmentation, the incidence of PJK is up to 20 to 30%. So it really doesn't help that much. What I could tell you is that I do a lot of revision operation for patients who are referred to me, and doing a revision operation when there's a bunch of cement there is a much harder revision operation than just doing a small posterior column osteotomy and extending that patient up higher. The other thing that's been looked at is the type of instrumentation at the upper instrumented vertebra. And here, initial studies showing that hooks are better than screws. Some initial studies also from Cal Kabesh saying that it's 0% when you use hooks. But I don't believe that at all, actually. When we looked at our multivariate analysis, there was really no differess that we saw. You can see the p-value here not approaching significance at 0.13 and 0.2. And you can see here, this is a case from a colleague of mine, Dr. Shea Bess, showing that even when he used hooks, PJK still occurs. So instrumentation type is really not the answer. UIV has also been discussed as far as where you stop your proximal fusion, and that makes sense biomechanically as well. This was a paper from Jean-Marc Tong looking at the FEA analysis of the weight, the percent of your body weight that's on the upper instrumented vertebra. So if you stop in the thoracolumbar junction, the weight is about 2%. When you go higher, it's about 1%. So that makes sense for us biomechanically that, hey, if you go up to T2 or T3 for your reconstruction, maybe you could avoid PJK. But I could tell you that the literature also has not shown that to be true. What we see here is that the PJK angle at 1 year and 2 years, whether you stop at the top or you stop below, is the same, and the rates of revision are the same too. And that's not just our data or the data that I'm presenting, it's also data from other colleagues internationally. This is a paper from Matsumoto in Japan showing that the PJK incidence is the same, the incidence of symptomatic PJK was the same, as well as the revision rate for PJK. Now we look at soft tissue augmentation, and this is something that I've looked at because it also makes a lot of sense biomechanically. There are contributions from all 4 of those blue arrows of the interspinous ligaments, the capsular ligaments, the ligamentum flavum, the interspinous ligaments that contribute to the posterior tension band. And the idea in theory is that if you augment these tissues, you could prevent or decrease the incidence of PJK. And this is something I've been doing for a little while, and we studied these patients prospectively, and what I could tell you is that even though you do it, it still happens. So this is obviously something that is a real enigma to us, and it seems to occur constantly. When we used the tape, there was a little bit of a difference in the incidence, but it wasn't statistically significant. And the cases for revision were too small to actually have a significant statistical analysis. If we look at some of the literature of the MIS surgeons who say that maybe if you just use percutaneous screws proximally, that you could avoid PJK, but here you could see that Praveen Mumaneni with some of the studies from the minimally invasive sector of the ISSG demonstrating that the incidence of PJK is similar between the two, 48% versus 53%, and the revision rate also similar. Modifying the magnitude of correction is also something that I alluded to before when I talked about age-adjusted correction and criteria. And what we have found is that when you try to correct patients less aggressively, you have a potential for reducing the problem of proximal junctional kyphosis. But the other things that we must pay attention to are things such as age, osteoporosis, which is very important. We found osteoporosis to be a significant factor, as well as the concept of frailty. And here in this study, the odds ratio of 2.4, relatively high correlation with the incidence of PJK. Also, something that we cannot neglect is the soft tissue and the muscle. So if you have a patient like this who has very poor bone, and not only that, but very poor soft tissues, a lot of fatty infiltration of the muscles, that might be somebody that you say you might want to extend their fusion more proximally. So as I've outlined in today's talk, there's multiple reasons why PJK occurs. It's a multifactorial etiology, and it's most likely that the solution to this is not just one element. It's not just cement. It's not just posterior tethering or augmentation. It's looking at the whole patient and trying to fix many of the issues that are contributing to this very big problem. Thank you very much.